Hi everyone, my name is Anna Flores. I'm a first year respiratory care student from Malcolm X College. Today's topic will be discussed about the indications of mechanical ventilation. The indications are the following for mechanical ventilation. Patients fail to ventilate on their own. We can indicate that by reviewing their blood gas, their arterial blood gas, to see how high or low their PCO2 is, meaning their carbon dioxide levels, more whether it's more than 50 millimeters of mercury or less than. We would see if the patient fails to oxygenate because their arterial O2 tension decreases. We can see that through their PaO2, again through the blood gas, is less than 50 millimeters of mercury. Or we can also look for their pulse ox reading, which would be their SpO2 falls either 90% or below. Again, because going through the oxygenation dissociation curve, we see that the PaO2 is at 90%, then the saturation would be at 60, which is still okay, but borderline to the curve. The patient can also exhibit acute respiratory muscle failure from a disease such as ARDS, acute lung injury, CHF, and sepsis. The patient can have an acute exacerbation of CAL, that is refractory to conservative therapies. Or lastly, the patient is unable to protect their airways as a result of trauma, neurological dysfunction, anesthesia, or drug overdose. In summary to what I just discussed is basically the patient either has a ventilation problem or they have an oxygenation problem. So really what a ventilation issue would look like is that the patient would have hypercapnia, respiratory failure. Some examples are the following. The patient can have their respiratory drive reduced, their chest wall has some abnormalities, their they are respiratory fatigue, such as their diaphragm gives out, and then their body would have to compensate with using their accessory muscles. Since again, our diaphragm does 90% of the work of breathing, meaning all that energy is given to the diaphragm, and it's like, hey, pump, 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 make sure I'm breathing, guys, and sends it throughout your whole body. The patient might be retaining CO2 and they're trying to blow it out as best as they can, but they're using so much energy and so much force to try to get that out that the diaphragm can give out, which would cause fatigue. And once that were to happen, their accessory muscles from their thorax cavity and above will start to compensate to help the whole body release that CO2. Then, if it's not any of those, then it would be an oxygenation problem such as intrapulmonary shunt, VQ mismatch, or decreased FRC. As we talked about before, we talked about full ventilatory support. Again, to remind you what it is to provide minute ventilation and to provide the patient's full work of breathing, in addition to normalizing the patient's ABG. Now, the theory behind it is basically us as respiratory care practitioners, we're providing a patient's breath. We're providing a patient's tidal volume. And again, if you needed a reminder, tidal volume is the amount of air we breathe in and out. So if you really think about it, we have the capability to determine how much they're able to do, what the patient's able to do. But we can also recognize as respiratory care practitioners what they can't do, what their situation may be through an ABG, and how severe the patient's condition is. Are they in a mild state of hypoxemia? Are they in a severe state? How fast do we need to intubate? Do we need to make a decision whether he or she needs a non-invasive or invasive tactic? So all of those critical thinking is based on whatever we see in the signs and symptoms of the patient. Because some patients are able to ventilate through non-invasive tactics, and that's okay as long as they're compliant and it's helping their vital signs go to normal range, to their normal range, depending again the condition that they may be or are. It may be different for a COPD patient compared to a cardiac patient, or depending what the disease severity is formed. Um, and it's also the only way we can actually know that the mechanical ventilation is working for the patient is that their underlying cause is being resolved. And once that were to happen, then we can decide what proper protocols to follow for weaning off the patient, meaning taking them off ventilatory support, and to see how compliant they are, whether they need a non invasive tactic right after their weaning off of mechanical ventilatory support or not. Three examples of patients that will need um, mechanical ventilatory support would be a patient that's status asthmaticus who had a moderate to severe exacerbation, so their airways becoming more constricted, their bronchial smooth muscle starts to close and narrows down really, 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 really tight to the point where they can't breathe and they can't um, basically blow out the CO2 that they have because they're air trapping at this point. So then they would intubate the patient and provide ventilatory support. Another example of giving ventilatory support of mechanical ventilation for a patient would be a patient with ARDS. In a mechanical ventilator, depending on the mode, usually ACVC mode, for an ARDS patient, we would give them a high PEEP and we would also give them a high respiratory rate, which is a high frequency. And we would adjust the FiO2 depending on how moderate, severe, or if the patient's improving status to basically keep their alveoli open because their alveoli is consolidated. And lastly, a prophylactic problem I believe would be like hospital slang that they would say a freaking flyer. Somebody who's constantly going back to back to the hospital who, for example, a COPD patient, there's been cases where they already know they need to be intubated because they've done this before and it's helped them breathe, whether it's a day or two, and then they get off and they wean the COPD patient off to just help them ventilate because they know that again, a COPD patient has already a problem breathing out the CO2 because they're air trapping. So they would need a longer E time. And in order to do that, they can also be provided mechanical ventilation to help them breathe. So, with all of these, this is a summary of how mechanical ventilation indications are. And I gave you my three examples of different kinds of patients that would need it and signs and symptoms that you would find in the clinical manifestations in your hospital. I hope this helped you and see you next time for the next video.